Good afternoon, everyone. Thank you so much for joining us for our webinar this afternoon. Today we'll be continuing our price transparency series, and today we'll be focusing on how to advance patient cost transparency using HL7 FHIR. And we have a couple of wonderful guest speakers, Vanessa Candelora and Alice O'Carroll, who I'll let introduce themselves in just a couple of minutes, who are going to walk us through today's topic. But before we do that, I'm going to go ahead and go over some brief logistics with the audience. Today's session is being recorded. All attendees and registrants will receive a link to the recording after the webinar. Microphones are muted throughout the presentation. However, if you do have a question you'd like to communicate to any of our speakers, please feel free to use that Q&A function at the bottom of your screen and submit your question at any time. We'll have some time at the end to answer audience questions. All right, so I mentioned we have some wonderful guest speakers today, and I'm going to have them go ahead and just take a minute to introduce themselves, starting with Vanessa.
Thank you so much. First of all, I appreciate the welcome and very excited to be here. So thank you for the opportunity. I am Vanessa Candelora. I'm from Point of Care Partners, and I co-lead the HL7 Da Vinci patient cost transparency use case. And I'll turn it to Alice.
Good afternoon, everyone. We're very excited to be here and share what we've been doing in the Da Vinci Cost Transparency Work Group over the last few years. I am currently the lead digital product manager at Florida Blue over interoperability and modern security. So we're very excited to be with you guys today and to share what we've been doing. Rachel?
Hi, everyone. Followed by these two amazing women. Rachel Goldstein, I'm the Vice President of CAQH Core, which is the initiative within CAQH that runs business rules for being more efficient in the exchange of information for healthcare. And I think this topic is really special because it sits at the intersection of, compassion, right? And also efficiency. And I think that's really the sweet spot for what CORE focuses on and what I know these two speakers care a lot about as well. So looking forward to getting into it.
Great, thank you all. I'm going to go through our agenda briefly, and then I'll pass it off to Rachel to kick off the presentation. We're going to start with just a really brief core overview and our engagement with price transparency over the past couple of years. And then the bulk of the presentation will be given by Alice and Vanessa, who will really walk us through the cost transparency landscape and also the work that the Da Vinci Patient Cost Transparency Work Group has been doing. We'll wrap things up with a discussion, and then we'll have some time for audience questions. And last but not least, we'll provide you with a brief call to action at the very end. And with that, I'm going to go ahead and pass it over to Rachel.
Thanks, Jackie. And like you can probably tell, Alice and Vanessa are really our subject matter experts here who will be sharing a lot of their wisdom. And I mean, they're both leaders in this space. They've also rolled up their sleeves and done a lot of personal work on this topic. So looking forward to hearing them speak. Before we get into that, for those of you on the line who aren't as familiar with CAQH Core and what we offer for industry, wanted to just give a 1-minute overview of who we are. So we were founded about 15 years ago at this point, really to ease information exchange between health plans and providers, of course, with vendor organizations that support those stakeholders, often sitting in the middle. And to date, we have 10 operating rules, which are essentially business rules that can be applied to existing standards to really improve that exchange of information even more and apply to specific use cases that a standard may not necessarily already address. We have 10 that are federally mandated under HIPAA by HHS, CMS, and we do have a mandate authority, which is great, but we also put out a lot of thought leadership and have some voluntary rules and industry resources that are really helpful for industry across the revenue cycle and interoperability in general. We've estimated that industry can save 18.3 billion through moving towards more automation from manual processes to automation. And again, This is across that interoperability administrative side of healthcare spectrum. We do our work. We have an amazing staff that has great subject matter expertise across the interoperability space and in the implementation space, but we also are really fueled and founded by our participating organizations and our multi-stakeholder board. So we have over 100 organizations. The health plans that participate with us represent over 75% of covered lives in the country. And we have several very large provider membership organizations and provider organizations, vendors, advisory bodies, standards development organizations, and state healthcare organizations. So we're very multi-stakeholder, and we love to host forums like this to educate industry on areas that really require that multi-stakeholder collaboration. We could move to the next slide. I'll just share very quickly how we've been engaged in the price transparency space to date, just in case any of these resources are helpful for you. And I know Vanessa and Alice will be talking about some resources that are also available with the organizations that they work with. So in 2021, we convened an advisory group focused on advanced explanation of benefits, and we published some industry guidance in that space. There's a link to the paper here. This presentation will be available to you, like Jackie said. It's really about approaches for the good faith estimate exchanges. We also have continued with the education series. This is one in a series of many other webinars and education events that we've done in this space. And also just this year, we submitted a response to the notice on proposed rulemaking for the No Surprises Act, addressing the proposal to require the use of CARCs and RARCs, those adjustment reason codes. So that's just a very brief overview of some of the resources that we can offer. And with that, I'd like to turn it over to our esteemed guest speakers for the day.
Thank you so much, Rachel. That was great. And so Alice and I are going to go through the DaVinci HL7 FHIR patient cost transparency use case. Next slide. Next slide. We'll start with a overall landscape just to ground everybody in sort of what this is all about, right? Many of you may be familiar with the No Surprises Act and patient cost estimates, and we really like to ground people in that patient experience. And you're going to hear that as a theme throughout our presentation, you know, how we're centering patients and all of the work that payers and providers and vendors are coming together to do. So Alice, to you.
Yeah. So as everybody can kind of see with the visual that we've created here, this is probably for everybody on this call, you've probably experienced something like this on the left side of your screen, where you get a bill and you're like, wait, what? How is this possible? In this example, you know, we're using something that is supposed to be an automatic covered no matter what, which is a mammogram. And, you know, understanding that it's because where she was sent and she now owes $700 and like, what? And then that's where we are today and where we need to get to as an industry. And we've been making baby steps for many years, but we're still not where we need to be, is to this beautiful place where we're happy and we're like, this is amazing. My doctor got me to the right place. I got the great care that I needed. I had a high quality mammogram, you know, happiness and smiley faces versus, you know, sadness and, you know, how am I going to pay this bill? And that's what we've all been working on. And I think everybody, again, probably has experienced this personally, at least once in their life. So if we can go to the next slide, please. There has been a lot going on both at the federal level and the state level around cost transparency. And this slide has a lot of detail on it, but what we really want everyone to take away is that, you know, we're here now in 24. This all really started about a year ago. There's new stuff coming out that we're looking at in 27 is going to be some requirements. And there's a lot of things going on at the federal level. And then if you'll go to the next slide. This gives you a visual of what's happening at the different state levels. You can see here by the color coding that different states have tried to pass cost transparency rules for the people in the state. 6 of them have actually passed. 2 actually passed and required it be in the FHIR format. There's 8 proposed, 3 that have failed, and then 35 that haven't really done anything yet. But remember, you now then have, with all these ones that have passed something, you have federal regulation and then you have state regulation. And that can get really, really confusing really quickly. Can we go to the next slide, please? So we were talking just about the federal regulation around cost transparency. This slide is diving in a little bit more towards looking at interoperability and exchanging data in the FHIR format, specifically in form of CMS regulations that have been slowly coming out. And we kind of use this step visual to help everybody really see that it started, a few years back with 9115 coming out and requiring payers to start exchanging clinical and claims data with third-party apps as well as other payers. And then right on the heels of that, CMS passed the 9915, which is the transparency and coverage. And literally the following month is when Congress passed the No Surprise Billing Act. So again, you have even competing federal regulations in the cost transparency space, one from the government and one from a government agency. Then they rolled out the Trusted Exchange Framework and Common Agreement, commonly referred to as TEFCA, which, if you're not familiar with TEFCA, think of like a state HIE on steroids. This is really creating that kind of network of exchanging data, but not just at the state level, but at the national level. And again, in this new FHIR format. We're kind of assuming here everybody's heard of FHIR, but if you haven't, it's FHIR, and it stands for Fast Healthcare Interoperability Resource. And it is the new standard, the industry standard in which all of this regulation is trying to get us as an industry to transition to. And there's a lot of advantages to exchanging data in the FHIR format. One of the best examples that we can really use for this is Legos. So think about Legos in terms of you get that set, and in the set you can build the Eiffel Tower or the Empire State Building. And when you get it, it has all of the colors, shapes, and sizes you need to build that specific thing. That's kind of where our industry is now with our X12 transactions. Now, that is great. It works really well. The data is very interoperable. It goes from one place to the next. You're going to have all the data elements you need, so all the pieces that you need. It's just that it's not something that you can manipulate easily. You can't parse it and leverage the individual pieces easily. FHIR is more like old school Legos, where you have the box and you can reach in and pull out the colors, shapes, and sizes that you specifically need. So it makes it much more parsable and leverageable and reduces a lot of cost to the industry. And then you also don't have to redo the foundation every time you go from one version to the next. And it has also been versioned very, very quickly, whereas with X12 versioning has been much slower in progressions. And it's not that one is better than the other. It's just that there's an evolution, and the industry as a whole is being pushed towards the FHIR where you can pick and choose things more easily. So hopefully that gives you a little bit of an understanding of what FHIR data is, why it is, what makes it desirable, and why all of these regulations are pushing towards it. There's also the HTI-1, which was recently passed, and then there's another HTI-2, which is proposed, which is also pushing the vendors and the providers to also exchanging data in the FHIR format. So not only are payers, but vendors and providers are all going to be required by January of 2027 to have the ability to connect to API endpoints and exchange data in the FHIR format. So again, a lot of emphasis on that. Vanessa, I don't know, do you want to add anything to that before we move on?
Sure. Yeah. I mean, I think I'm actually going to be really lame and read what's on the slide, but this opportunities for market leaders or even, folks that are sort of the next step of leaders, right? Next generation of leaders. You know, these regulations are disrupting the entire healthcare business model in a lot of ways and are really catalysts for the industry to reimagine how healthcare works together. Payers, providers, vendors for both of them, and patients interact with each other and really get like interoperability and data flowing in a different way than we're used to seeing in healthcare. And we often make comparisons to the financial industry that went through a similar transformation years and years ago, decades ago now, and you know, the airlines industry. And now we're able to make better informed decisions about things like vacation planning, which we all want to talk about, right? We can go on to a Kayak or an Expedia, and there's APIs, application programming interfaces, that enable you to look at all those different flights, look at all those different things, and be able to plan your vacation, not just with flights, but with a hotel and a rental car if you need it, and, you know, really put your package together. And, you know, that kind of concept of enabling patients with information to be able to make informed decisions is not just about cost, which is what we're going to talk about mostly today, and the No Surprises Act aspects that go into that patient estimates, but you know, all of those different factors, right? The quality of your care, the location, the comfort of, you know, does your provider speak your language and have the services that are available to you and are in network. And you know, we talk a lot about how all these things come together and how data standards can support them. And you know, we're seeing a lot of positive disruption as these regulations come together, both at the federal and at the state level. And next slide, please. The No Surprises Act is not as new as we would think. It was actually passed in, I think, December of 2020 or 2021, and became effective of January 1st of 2022. And so Congress, this is a law that went through Congress. The No Surprises Act was part of the Consolidated Appropriations Act of 2021. And so it went through Congress and was passed as a law, and the industry has been sort of monitoring and seeing how it's going for the regulatory enforcement of implementing these requirements. And that's what will come out of Health and Human Services, our friends at CMS, as well as it's actually a tri-agency regulation. And I won't get into too much detail just in the interest of time, but there's a really interesting sort of dynamic in how, you know, this is coming together, and it's very multifaceted. There's lots of areas of the No Surprises Act that we're not going to talk about today, that you're seeing in the news relative to the independent dispute resolution side of the law or other areas. What we're going to focus on today is what is on this screen right now, which is the No Surprises Act establishes new consumer protections from unexpected medical bills. So getting back to our very first patient story on the slide that Alice went through. And those protections include requirements that help consumers, like giving them information about their expected out-of-pocket costs for healthcare items and services before their care. We often sign that agreement, you know, as we're going into the OR, right? That says, yes, I will pay my bill. I don't know what it's going to cost me, and I don't know exactly what's covered, but I promise I will pay it, right? And we have to sign that today, as many of you may be familiar with as patients, right? And trying to arm patients with that information in advance is what this really is, the spirit of this law. And so the No Surprises Act specifically requires that a provider or providers share a good faith estimate with a patient if that patient is going to be paying through self-pay or they're uninsured, or they need to share it with a payer for insured patients when the patient schedules a service or requests an estimate. And then when the payer receives that good faith estimate, or GFE, they will create an advanced explanation of benefit. So those of you may be familiar with your explanation of benefits that come after you have a service, this would be one in advance of services, and that should be made available to patients in advance. That's a summary. But that's where we're really going to focus today as part of the No Surprises Act. And we've seen some regulation already on the self-pay side of this work, and we are anticipating, the entire industry has really been anticipating the pay or the advanced explanation and benefit side of this regulation, which is complicated, as you may already know, or will definitely see in our presentation. There's some loose expected timelines of March of 2024 for a notice of proposed rulemaking, or NPRM, based on the unified agenda. And so in a recent April 2024 CMS update on progress towards the AEOB rulemaking, they did mention that they are seeing the HL7 FHIR standard and the work that Alice and I and the whole community within DaVinci for patient cost transparency holds potential for supporting an interoperable exchange of insured GFE and AEOB information between providers, payers, and patients. So we're pleased to see that we're well aligned and providing an option for meeting this regulation through standards approach. Next slide, please. So the way, oh, go ahead.
I just want to interject real quick. You know, when you talk about when you have the regulatory body that is trying to make sure that what Congress enacted is happening, and there were pieces of what was enacted into law that were fairly easily for the industry to implement. This piece of it has been really, really challenging. And we were kind of excited when we saw that update, that they saw a lot of promise in the work that we were doing. And we're going to talk a little as we go through this. We're also going to share some like piloting that we're getting to that's making this look like it really can be the solution that will allow the industry to finally get where we need to go. But go ahead, Vanessa.
Great, Alice. Thank you for sharing that. Alice already mentioned FHIR and what it is, and FHIR is a standard for syntax and data exchange, and a model that is under the umbrella of HL7 International, or Health Level 7 International, which is an international standards development organization. And DaVinci is a project within that, which we'll get a little bit more into. DaVinci is what's considered a multi-stakeholder collaborative. And so building a community that brings the knowledge, you know, experts in the field across the industry, the right stakeholders and leaders in the right home, a standards development organization, plus a process to use draft standards that are built out in the open, in the public sphere, with early adopters that want to address these needs using this FHIR technology, can adopt it across stakeholders. And we do a lot of matchmaking at connectathons for testing, plus a methodology. So we have a rapid development cycle of an implementation guide spec, and supporting reference implementations, which my colleague used to refer to as eating our own dog food. And so we build the spec, and then we actually have to implement it and learn from it and test it and fix those problems, so that we're iterating on the spec. Because I came from a private sector, and I always used to wonder, who wrote these standards, right? What were they thinking? This isn't going to work in the real world. And so this is our way to bring the real world in early and often, and learn and iterate on those standards. And so that's what we consider a successful model. Next slide, please. All right, the DaVinci cost transparency work. So this is a summary slide of our implementation guide and the use case. The little dial there shows our progression towards maturity. And so the blue color means we're of moderate maturity. We are in our standard for trial use 2 balloted version, which means we've already published an initial version of this that was focused on a certain scope for GFE providers to payers and payers AEOB out to patients, with an optional copy of that patient AEOB to the providers, because we heard from our community of providers that it was essential that they be able to understand what a patient's costs would be, so that when their patient calls them and says, hey, what's this cost about, they are informed with the information and can make decisions collaboratively as a care team with the patient included.
And if I could just kind of interject real quickly on that, just to kind of bring home what Vanessa was saying on the previous slide, coming into this slide about Da Vinci being a multi-stakeholder organization. Each one of the work groups has a payer co-chair, a provider co-chair, and a vendor co-chair. So every single one of the work groups, cost transparency being one of them, has representatives from each of the three legs of the stool that kind of prop up our industry as a whole. So that, to Vanessa's point, when it gets rolled out to real world application, people aren't going, who thought this was a good idea? We have all the voices along the way. And to Vanessa's point with this particular one, the providers were going, wait, hold on. That may sound good to the payer and to the vendor, but that's not working over here. So when she was kind of being, making the analogy of, making your dog food and then eating the dog food, we figured out real quickly if it tastes good or not.
Yeah, that's great, Alice. Yeah. We also heard from the payers too, right? We hear, we're working very hard to align with what's happening across not only Da Vinci, but the ecosystem of where people are, right? And hopefully if you walk away with something, you walk away with that from this presentation, because, you can see in sort of our looking ahead in the bottom right corner that we're aligning with US core FHIR profiles of data resources. 6.1.0 is an upgrade from the US core 3, which is where we are now. We have a lot of let's not reinvent the wheel, right? Let's leverage, for example, member match that many payers implemented with the patient access API and the PDEX guide, and other things like that, that some of our early adopters have felt was really helpful for them because they didn't have to reinvent the wheel. And so there's a lot of synergies there that are sort of reducing the burden of implementation as well. Next slide, please. Alice, did you want to talk a little bit about Da Vinci? We kind of covered some of this, but feel free.
Yeah. But again, we talk about the different pieces of, you've got the regulatory piece of things, right? Whether it's, a CMS mandate or Congress enacting a law, which in this space, we've seen both happen. Then you have the piece of, it's not free. It costs to figure out how to be compliant, especially when you have competing language in a CMS regulation versus a law enacted by Congress. And then the thing that matters the most, which is why CMS is putting out regulations, why Congress is enacting laws, is to have better patient outcomes. And when you have all three of these things overlapping with each other, as we show in this Venn diagram, is where the value truly comes out. And Vanessa was just referencing how in Da Vinci, there's been multiple different work groups that have focused on different things. And when you can reuse, if you will, and leverage a particular IG to help support multiple different outcomes, there's a lot of value in that. And that's where the value-based reimbursement and value-based care really comes into all of this. And there's been a huge, if you've been in the industry, you know that for the last 15 plus years, there's been a huge focus on driving towards value-based care and making sure that the patients are getting what they need and the outcomes that are expected are happening. And all of the regulatory and congressional laws are coming in, and then we're trying to help bring down the costs by making things that are reusable. And this is, of course, making sure that we're looking at things that are, high volume, being able to lower manual activities, make things more automated. And when you have implementation guides that can be scaled and used in the payer and the provider space with vendors kind of connecting it all together, you get a lot of that, cost to come down. And that's why we focus on a lot of these overlaps with things. Vanessa, I don't know if you have anything you want to add to that.
That was great, Alice. Go ahead.
Yeah, next slide, please. So really what we're trying to do here is help make sure that we are a part of, and when I say we, Da Vinci, are a part of the industry being successful in this shift to value-based care, that we're making sure that we're being a part of transforming things out of, creating some controlled chaos, bringing all the pieces together, the collaboration. We talked about making sure that we have payers and providers and vendors all involved. And then, of course, using the FHIR-based implementation guides and doing a lot of pilot projects. And we're going to be sharing with you a little about our IG for the cost transparency and a little bit about some pilot projects that are going on as well. Vanessa, do you have anything you want to add before we move on? All righty. So next slide, please. So why now? What's different than, 15 years ago, 5 years ago? The difference is we are starting to see some real world progress. Implementation is happening. We also have a lot of support, if you will, from our regulatory bodies and our lawmakers, both again at the federal and state level. A lot of the barriers to clinical data sharing have been able to come down by implementation of some of these IGs that we've put together, and not just in Da Vinci. There's several other industry work groups that have been incredibly important in getting us there and getting a common language and getting FHIR really created with the USCDI data standards, et cetera. And then, of course, the other piece of the pie here is reducing the burden and doing the true shift to support true value-based care outcomes. I don't know, Vanessa, do you have anything you want to add to that? All right, next slide, please. And Vanessa?
So this is a view, and I'll cover this really quickly, but you can see Da Vinci has a lot of different implementation guides that are each targeted towards a specific business problem or use case, and they can work together in collaboration. So for example, in the top right corner is our coverage, transparency, and burden reduction. So those top three top three dials for coverage requirements discovery or CRD, and documentation templates and rules, DTR, and prior authorization support, PAS. They all work together and are recommended by the 0057 CMS final rule for reducing burden to further automate and enable data exchange for prior authorization. And so each of these, they can work sort of as foundational or together as building blocks, kind of getting back to Alice's Lego analogy from earlier, to support your business needs as you think about your journey towards implementing FHIR and other modern technology and APIs, how you can leverage standards to accelerate your implementations of some of those business problems you may be tackling. Next slide, please. So Da Vinci Patient Cost Transparency, we actually started this 4 years ago, and we began with Da Vinci members coming together and saying, hey, we are seeing really big problems. I think at the time and still to this day, there's, the medical bill of the month of patients that are, going bankrupt over their medical bills. And we want to try to solve these problems and also improve our revenue cycle for collections and, make sure that patients are informed and we're not having member satisfaction issues, both payers and providers. And so people quickly came together, and we did a lot of discovery at first. So the transparency and coverage rule dropped one morning when Alice and I both remember we were in like a working group meeting, and we had like 4 hours dedicated to digging in deeper to patient cost transparency. And that very morning, this transparency and coverage rule dropped, and it kind of morphed our direction, and we've been sort of pivoting. And then in 2021, the No Surprises Act really gained traction, and we learned a lot about that and started building our requirements. We had a draft implementation guide in January of 2022. We published that in March of 2023, doing a lot of testing at Connectathons for a year, actually, to iterate on that standard. And now we're in our STU2, which we balloted in January, and we're going through a reconciliation of that ballot comments or community feedback before we publish our standard for trial use 2. Next slide, please. So this is the workflow, and you're going to see a series of workflow pictures here. So we have enabled an option for providing the this workflow. So there's the good faith estimate to a payer from a provider, and that is triggered by a patient needing a good faith estimate, whether because they scheduled a service or they request an estimate. And so there is a published FHIR option that is available for that GV submit. We recognize that there are other options in the industry, and we want to listen and learn and work together. This is not a claim. So there's no HIPAA mandated transaction for patient cost estimates. There are HIPAA mandates for other transactions, claims, remittance, but those may support cost estimate transactions as well. But this is a FHIR good faith estimate and a FHIR advance explanation of benefit to a patient. And then that advanced explanation of benefit, we also support a return to the provider, which is not mandated part of the law. It's not in regulation. Regulation hasn't come yet. But the Da Vinci community felt it was really critical for information equity. And good faith estimates and advanced explanation of benefits do not serve as a replacement for eligibility or prior authorization or any other financial administrative use case. They don't determine medical necessity. This is purely estimates as close to as good faith as you can get it for a patient, right? And it's different from an online shopping tool where you might have, many, because of transparency and coverage and because of the hospital transparency rule, there are online shopping tools for commonly shoppable services, right? We often use the example of a knee replacement. Right. In a knee replacement, there's a standard set of CPT codes that might go into a knee replacement. You're going to need an anesthesiologist, a surgeon, a facility, you need the prosthetic thing that's actually going to be implanted, right? Medications. And that can be sort of a package that comes on a shopping tool. These are different. This is, rather than this being, and I heard this last week and thought it was a really easy and great way to say it, which is, this isn't an estimate for a knee surgery. This is an estimate for your knee surgery. So specific to you, if you have a nickel allergy and they're using a different device, if you are prone to blood clots and they want to make sure they give you a blood thinner in the hospital and keep you overnight, right? There's going to be some differences there. So this is more specific, geared toward the patient, and it's based on knowable information. You're not going to know everything in advance of a service. So, I think claims and leveraging the data, right, that goes into a claim is important because that's what gets paid. And we want to align with that for estimates as much as we can for better accuracy, but recognize that there's not going to be as rich of a data that there would be on a claim for an estimate. Next slide, please. So we started out with the GFE and the AEOB, and then we realized we recognized that it was at the time, it was a bit of an elephant in the room of how is this coordination going to happen? So part of the No Surprises Act law is that providers will notify other providers involved in the care. So giving our knee surgery example, you're going to have the surgeon, the facility, an anesthesiologist, at the least, right? And coordinating to determine what that holistic picture of cost for the patient is going to be was something that we recognized really early on was going to be really challenging for payers and providers. And so that's what we've been working on over the last year and a half, which we started out just thinking through that piece together, which is where we are. And so coordinating, it is a deferred enforcement requirement for self-pay and uninsured patients. And the PCT implementation guide supports providers and facilities composing the good faith estimate when multiple providers are involved in the patient's care. Determining who the convening provider is and who the co-provider is, and that's words coming from the law, the regulation for self-pay. That is not what we define in the data standard. Okay, so we actually have technical actors that support those roles, and who determines that role is something that is not part of our standard. And depending upon what role they play, they would play one of these different technical actors. And it may involve additional actors, right? There's an opportunity for third-party vendors or tools that support these entities. Next slide, please. Okay. So on that same level, what we have is called a coordination platform. And so we introduced this technical actor called a coordination platform that could be in-house, right? It could be a facilities in-house practice management system or outsourced practice management system or EHR. It could be a cost estimator tool. It could be a clearinghouse or a billing services entity, or it could be a payer. A payer could serve as the coordination platform to ensure that all of those providers involved in the service are have aggregated their portion of the good faith estimate to enable that advanced explanation of benefit for a patient to be able to see their summary, right? At the end of the day, a patient really wants to see what's my out-of-pocket cost to be, where am I against my deductible? If I have a limit on PT visits, how many have I used already? How many do I have left, right? And then the ability to drill down deeper into more data. Next slide, please. Supporting all good faith estimates and AEOBs is putting the whole picture together, right? So if there's coordination needed with multiple providers involved, and then a good faith estimate submission to the payer with an advanced explanation of benefit out, we can cover the end-to-end workflow, which is all outlined in the PCT implementation guide. Whether there's one or more provider involved, you can do either. So this doesn't assume that there are more than one providers involved. You could still just have one provider send their information to a payer as well. And it provides detailed guidance using FHIR-based standards. It's again available optionally to the provider that submitted the information for that parity of information. Next slide, please.
So I was going to say,
go ahead.
just jumping in, but all of these requirements make the landscape really, really challenging. And Vanessa's going to jump in here and talk about how we're kind of checking all the boxes here. But please remember, as we've been kind of going through, and you saw there's a difference between, is it a self-pay patient? What happens when you have to get a payer involved? What happens when it has, with the knee replacement example, when you have multiple different types of providers involved? And what happens if, as you care about what is getting my knee replaced going to cost me? Well, we just, in that example where she was talking about the kind of the day of stuff, like, making sure you're on the blood thinners if you need them, and, you have a device that your body's not going to reject, and so on and so forth. But what about all the PT you have to go to afterwards? It's all these different pieces. Go ahead, Vanessa, sorry.
No, it's great. Bringing it back to the patient and making this real for them, I think, is the really important thing, and we don't do it enough. The challenging requirements are also very real and also very important. And to those of you that are payers or providers out there, you may be feeling some agita about this. It's a lot. This is a new business workflow in a lot of ways, and the technology can certainly support what this workflow will look like, and how we can automate wherever we can. But we do have to recognize that patient cost transparency is a little bit different than some of the other regulation that we've seen, right? And we're seeing some questions about regulation in the Q&A. And I think that, we have to recognize that there's still a lot to come in this regulation space. And there's a lot of sort of tricky, challenging requirements to figure out. And this is just the technical side, which frankly is probably the easier side, right? In my real world experience, the business and the people process is often very challenging too. And so, creating estimates in advance of services for every patient that walks in the door with the same workflow is something that we've really sort of aspired to get to. And we've done that and talked through these challenging requirements in a community consensus driven process. So the HL7 FHIR is an open standard, right? It's open source. There's no licensing for it. And so the development actually happens out in the open. You're all invited to join my weekly public calls on Wednesday at noon. And so I laugh because, it's really, if you want to see how the sausage is made, right? But we really truly welcome you. And so these things on this slide here are different areas of challenging requirements. So how are we going to do this multi-provider collaboration for a good faith estimate? We don't coordinate like that on the operations or payment side. We do on the clinical side, but we have to move a lot of this upstream in our workflow in order to accommodate that and really give a estimate on what your surgery will look like or your service or item will look like. There is a requirement within the No Surprises Act for a turnaround time. So if the service is scheduled between 3 and 10 business days, the expectation is to turn around an estimate to a patient within 1 day. And if it's scheduled more than 10 days out, the expectation is to turn around that estimate within 3 business days. And so APIs enables real-time or near real-time information to be exchanged, which helps meet that requirement. There's also an information gap. We talked a little bit about this, right? Providers' knowable knowns prior to a service is going to be very different than, the way a post-service payment process looks like, right? And so recognizing that was something we spent the first year on, essentially understanding what that minimum viable data set looks like so that the providers can feel confident that they'll have the information and that payers can feel confident that they're not creating an estimate on not enough information to be accurate if they're going to be held accountable for that accuracy. The workflow, we talk a lot about aligning with other standards and ways that we can work through that. So the PCT, there's a lot of discussion and excitement around the prior authorization effort with CMS 0057 and kicking off that CRD, which is the first step in the prior auth Da Vinci guides. Is this prior auth needed or not for this service? Also kicking off, there's going to need to be an estimate for this, right? A PCT call as well as an operation, as well as a CRD call can happen sort of at the same time in workflow. And so trying to align with that and working in parallel is something we've been discussing a lot lately. And we don't have all the answers there, but thinking through how best to align with real world workflows. FHIR inherently supports storage, so the requirement from the No Surprises Act for the good faith estimate to be made available as part of a patient medical record is enabled through our process as a vendor agnostic way to do so with FHIR. Accuracy. So getting accurate's really hard, that's a big discussion. And I think we need to do it and we need to iterate on it. And right now, when we talk to providers on the self-pay estimate side, they're actually checking all their estimates on the way out the door to understand, is this accurate? Is this something that makes sense to my patient? Or do I need to get on the phone and negotiate a little bit before we send this estimate out to a patient? Which is a good thing. All the requirements for the AEOB content, so benefit balances, what an out-of-pocket will look like. Is this service subject to medical management or prior auth or other things like that? Disclaimers and notes being available, having a consumer-friendly summary across providers if there's more than one to enable the making that actionable for a patient is really important. A reference back to the provider, good or providers The good faith estimate is a requirement from the AEOB. And, we're able to have that reference as part of the FHIR constructs. They're called bundles, FHIR bundles. And of course, an out of network flag. So, hey, one of the providers in here or this provider is actually out of your network. And here is a link for in-network options. If as part of the requirements from the No Surprises Act. So pulling together a holistic assessment. There's also a lot of concern. We've talked a lot about what if, we're coordinating all these different providers, and I'm going to pick on anesthesiologists. I'm sorry in advance if you're an anesthesiologist. I know you get picked on a lot. But what if, the surgeon and the facility get their portion of the good faith estimate in, and the anesthesiologist or any other provider, doesn't meet that deadline or doesn't get their estimate in on time? What do we do? Well, we have a way to represent what that provider, noting that provider's portion of the estimate is missing with, what service they would be providing and what their name is. And then lastly, APIs can enable patient delivery. And we often talk about what's stated in the law, which is the patient's delivery method of choice, right? And so, at the highest level, I think that's paper, right, or electronic, or is it a third-party app of choice as aligned with patient access API? Is it a portal? Is it an email? Is it anything? And so we have an API available that can support those options. And so we've talked a lot about these really challenging requirements over time, and again, we want to work with the industry on what's going to be best and make the most sense, and add value, and really try to get patients' estimates in advance of services however we can. Alice, did you want to add anything to that?
No, I think we, there's all this coordination that is happening, all these different places. And, there's been a few questions that have come up in the questions, and this isn't really answering any of them directly, but kind of in a general way. FHIR is the new industry standard. We're currently all using X12. Are we saying we're replacing X12 standards with FHIR standards? There's an argument to be made for both. X12 is very, very mature. FHIR is an infant. The industry is used to and is effectively using X12. X12 isn't quite as nimble. X12 is more like I use the Lego example, is more of, off the shelf. You have to build the Empire State Building or the Eiffel Tower or what have you. FHIR is the old school Lego, so it's a little bit more nimble. You can adapt it a little bit more easily. Are we going to be mapping from X12 to FHIR standards? There's a lot of work that's already been done into that. I think we're going to see a slow transition. Are we going to see somebody just turn the lights off on X12 and then turn the lights on in FHIR? No. Will we ever see the lights totally turned off on one and only be on the other one? That doesn't look like that's going to happen. We have to figure out, how do we make these things happen? And some of the questions that have come up, the difference between clinical data and the financial data, and what does HIPAA require and what is not requiring, and the fact that CMS has come out and started to give waivers on certain types of things, like around the prior auth, not having to necessarily be an X12 transaction if it's done in FHIR. So there's a lot happening and evolving in the space about which standard and how these standards are going to evolve. In unison, separately, we'll see. And that kind of answered 3 or 4 of the questions that are there in a vague way, but I wanted to acknowledge it. And Vanessa, I don't know if you have anything you want to add to that.
I think that was great. And we're seeing some good questions on, do we have a crystal ball for the regulations and sort of what ifs, and hopefully we've answered them well. If not, please reach out.
Yeah. So you want to go ahead and jump to the next slide? We'll talk a little bit about that
Yeah.
So yeah. So there've been quite a few, and Vanessa will chime in here too on some of the pilots that are going on. I will tell you, at Florida Blue, we are really leaning into this We've been allocating some resources internally. We have a large regional surgical provider and their EMR who have leaned in and said they really want to partner with us on this. So we're optimistic that within the next year, we're going to be able to show that this really can work, and start answering some of those right now unknowns about, how feasible, like Vanessa said, who designed this? In the real world, this isn't working. We figured out going through our STU1 that this convening provider thing was the barrier. Until we can figure out how to get all the different providers and all the different pieces together, and it's going to require providers to do something they've never had to do before. And they're already completely overburdened administratively. So how do we use technology to not make it an additional burden? And I think one of the questions had been, do you see providers having to document differently? I don't know if it's so much doctors documenting differently or providers documenting differently as it will be the vendor enabling support staff within the provider's organization to pull out the meaningful pieces to be able to submit that, in the case of having to submit to the insurance company for them to kind of do a fake adjudication on what that would look like. So I think that's where we're going to see things go, and we're going to see if it's going to work. Vanessa, what other things have you seen out there in terms of pilots and where people are going?
Yeah, it's a great, thank you so much, Allison. We're really excited to be moving forward with some piloters already in early stages. And if anyone on the call today is interested in piloting or wanting to learn more about what that could look like, please consider joining us and bringing exchange partners with you, or we can help match you up. You can reach out to the email address that's on the screen, which is davincipmo@pocp.com, and we'd love to hear from you. We're really excited to see this in action with real world settings, and we have, as Alice mentioned, and then we also have some providers that are really interested in doing this. We have some vendors that are really interested in doing this. We have kind of matching people up right now is where we are. So please join us if you're interested, and thank you. And I recognize we've got just a few minutes left. I think that was close to our last slide. Please go ahead. Yeah. Okay.
Great. Thank you both so much. I know we only have a couple of minutes left. Rachel, is there a quick question we wanted to ask for the discussion section, and then we'll wrap things up?
Yeah, I know a lot of people, anytime we're talking about new standards and implementing new technology, folks ask about ROI. And I know that's a difficult topic, but I was wondering if the two of you could speak about your perspective on that. Even if it's from kind of like the intangibles point of view.
Well, I'll go ahead and lean into that question real quickly. That is, in the traditional sense of an ROI, you want to say, what is immediately going to be, dollar to dollar, cost reduction or what have you. Here's what I would say about ROI for this cost transparency work is that there's two places that are kind of less tangible, but really, really important and equate to very tangible things, especially from a payer perspective. This is also from a provider perspective, but the abrasion the patient has of not knowing do they put stuff off because they don't know? Do they get misinformation because each individual person involved in the surgery told them, and they actually think this is going to cost them $30,000 because their deductible was counted 5 times instead of just once. So, there's the reduction of abrasion because people have real information to make good informed choices. That reduces, from a payer perspective, that reduces both provider and member/patient abrasion, because your providers are super happy and excited because they're getting real information from you that helps them make their patients happy. The patient is happy with their provider and the payer because they're getting the information they need. They're also getting the care. So that goes into the value-based care portion of it, right? People aren't putting off things that they need to do. And then, if you don't do things in a timely manner, you may wind up having to spend way more money and cost the system way more money because something becomes, an acute exacerbation of something that if you'd had the proper care or service at the right time, it never would have gotten there, right? If you'd had your mammogram, right? Then I literally just had dinner with a friend last night who has recently become uninsured intentionally. It was for a brief period of time. And what turned out that they did have something show up on a mammogram, but their mammogram self-pay was literally a quarter of what their copay was with their old insurance plan. Make that make sense. So these are all the types of things that when we get to where we have proper cross transparency and a provider can tell their patient, here's what it would cost if you go through your insurance, and here's what it would cost for you if you choose to go self-pay. Those are real ROIs to the industry, to the whole healthcare ecosystem that we will see. We just have to get to where we're doing this well before we're going to be able to say, an exact dollar figure around all these different types of ROIs. So that was like kind of a big picture vaguey, but hopefully that helps give an answer around what are the ROIs around this, because they're really significant. Vanessa, do you want to add anything?
Well, I know we're at time, and that was so excellent, Alice. And again, I think personal stories really clinch it, but, making a business case and having an ROI and being able to describe that as an essential part to what you need to be able to do within your organization to move the needle on implementing something. And so, hearing those insights, Alice, I think is important, and happy to talk about that for another hour if we want to.
Thank you all for having us.
Thank you so much. This is
We'll
great.
need to bring you two back and continue it. This is a fantastic topic, and I know everyone enjoyed it. So thank you on behalf of CAQH, and I'm sure we'll all be back. Thanks everyone for joining.
Bye. Thank you.
Take care.